Hi everyone. I'm delighted to talk today about the cephalocele, the incidence of cephalocele, the definition of cephalocele, and what is the differentiations between the encephalomeniнгocele and meningocele. Encephalocele is the protrusions of cerebral and or meningeal structures through a cranial bone defects of variable size. The incidence of cephalocele is 1 in 4,000 to 1 in 5,000 live births, and as we said, this is a cystic structures of variable dimension protruding through a calvareal bone defects, most often in the occipital regions, which is with brain tissue, which is called encephalocele, without a brain tissue, which is called meningocele, and it carries a high risk of chromosomal as well as non-chromosomal syndrome. The chromosomal associations is very high, is around 15 to 20%. The outcome is very bad. In case of encephalomeniнгocele, the mortality rate is from 40 to 50%. If alone meningocele, the mortality rate is from 5 to 15%. The etiology and pathogenesis is most likely a result from failure in the fusions of the neural tube defect, or and sometimes it could be due to amniotic band. Cephalocele may also caused by amniotic band. So this is the solid tissue. This is meningoencephalocele, and this is the meningocele alone. So there is no protrusions of the brain tissue outside the skull, but there is a defect and loss of mineralization in the occipital bone. How we diagnose the meningoencephalocele? I'm gonna to talk about this case, which is 14 weeks plus 5 days. I'm gonna talk about the meningoencephalomeniнгocele. It's round cystic, it's a solid mass in this case, seen protrusions from the claverial outline. Usually the sites of the protrusion, it's the occipital bone, it's most likely, but could be in the frontal bone. Also, the size of cephalocele may vary, and the small ones may also escape perinatal diagnosis due to the fact that the extracranial component is extremely small. The diagnosis can be made as early as at the 12th week of gestation. At the diagnosis, the sonographic aspects of the herniated mass varies from completely anechoic to mixed echoic structure, depending on whether only the meninges of the cerebral structures are involved, and the herniation of the cerebellum, as in this case, called as Chiari 3 malformation. Occipital cephaloceles are usually revealed on transthalamic view, but the mid-sagittal view of the fetal head, if obtainable with a posterior approach of the coronal one, may clearly demonstrate both the bony defects and the meningoencephalocele. This is the transthalamic view, and as we see, there is a cerebellum in the protruding from the occipital bone. In this case, this is the cerebellum, as we see. Here we are, and this is the defect of the bone. The differential diagnosis in cephalocele, it could be difficult in cases of hemangioma and cystic hygroma. Is easy, sometimes is difficult, is if there is a hemangioma. Now we're talking about the associated abnormality. There is an extra CNS associations and a CNS malformation. The CNS malformations could be the absent cavum septum pellucidum, holoprosencephaly, microcephaly, and spina bifida. Extra CNS abnormality is reported in association with cephalocele, including congenital heart disease and skeletal dysplasia of particular importance in the diagnosis of cephalocele. In context of Meckel-Gruber syndrome, this condition shows an autosomal recessive inheritance pattern. Therefore, subsequent pregnancies should be monitored as early as possible to rule out recurrence of the syndrome. The risk of chromosomal anomalies, mainly trisomy 13 and 18, relatively is high, as we said before, from 15 to 20, from 5 to 15 percent. And there is a significant, this is a corona view. Here we are. Yes, this is. Okay, so risk of chromosomal anomalies is relatively high, as we said, and there is a non-chromosomal syndrome and conditions such as amniotic fluid band, which is combinations of cephalocele, amputations of digits or limbs, facial disruption, frontal dysplasia, cephalocele, hypertelorism, anterior cranium, bifidum occultum, widely set nostrils, and median cleft lip or palate, Mickel-Gruber syndrome, cephalocele, polydactyl, polycystic kidneys, and other CNS abnormality. Now, obstetric management. Obstetric management includes a thorough search for any associated structures anomalies in order to rule out or confirm the presence of one of the syndromatic conditions mentioned above. Karyotyping so is recommended, microarray is recommended, and involving of the genetist is very important to send a whole exome if it's the first time. For example, the treatment for cephalocele is variable. If it is legal in the country and the family is not committed for this pregnancy, we can terminate the pregnancy if it's allowed. So it's better to do CVS or early amniocentesis to diagnose at least the cause of the cephalocele. In this case, the family opted not to do any invasive test, and they opted for termination and non-continuation of this pregnancy. If we continue the pregnancy, we have to do cesarean section at 38 weeks due to possible of birth injury. Postnatal treatment, very large lesions have an favorable prognosis and very poor prognosis, and there is no benefit for treatment. Small cephalocele can be corrected, small cephalocele can be corrected surgery. Prognosis, survival, and quality of life. These depend on the dimensions and the locations of the lesions, on the presence of cerebral tissue in the herniated sac, and on any associations with hydrocephaly or microcephaly or at the extracranial pathologies. The postnatal mortality rate varies from 30 to 40, as we said before, depending on the above mentioned parameters. Meningocele and anterior frontal locations are associated with lower mortality rate. Thank you for your listening.